Hello friends, the topic we will discuss now is autocoads. So as the name tells, these are the substances which have autocrine effect. Autocrine effects means local effects. And on the basis of chemical structure, we have three types of autocoads. One is peptide autocoads, which we covered in cardiovascular system like angiotensin, bradykinin. These are peptide autocoads. Then we have amine autocoads like histamine and 5-hydroxytryptamine or serotonin. And lastly, we have lipid autocoads like prostaglandins, leukotrienes, and thromboxane. So peptide autocoads we have already covered in cardiovascular system. So here we will start from the amine autocoads, and the first one will be histamine. Histamine, it acts through 4 receptors in the body, sequentially named as H1, H2, H3 and H4. Out of these, most of the actions are done by H1 receptors. H2 receptor is mainly present in stomach, and its prominent function is to cause secretion of acid in the stomach. That's why H2 blockers are used in peptic ulcer. Then H3 receptor, it is a presynaptic receptor. It is acting like a brake. H3 receptor is a presynaptic receptor. Just like alpha-2 receptor in the sympathetic system, H3 receptor in the histaminergic system acts like a brake. H4 receptors are mainly present on WBCs. Exact function is not known. Now most of the actions of histamine are through H1 receptors. So histamine has two very important actions. One, it is involved in causing allergy and inflammation. So most of the features of allergy and inflammation are mediated by H1 receptor. So by stimulation of H1 receptor, there is vasodilation, there is bronchoconstriction, there is increase in permeability. So all features of allergy and inflammation are mediated by H1 receptors. Secondly, H1 receptors in the brain, it stimulates the reticular activating system of brain. So basically it promotes wakefulness. Stimulation of H1 receptor promote wakefulness. We are awake because H1 is being stimulated in the reticular activating system of brain. Now recently we have developed a drug which is H3 receptor antagonist, or we can say inverse agonist. So if a drug is H3 receptor inverse agonist, that means it will cause failure of brakes. So when the brakes fail, H3 histamine will be released more than required. So when more histamine means more wakefulness. So that we can utilize in treatment of narcolepsy, condition characterized by sleep attacks. So we want to decrease sleep. So we want to promote wakefulness. So we will cause failure of histaminergic brakes. So when more histamine, more wakefulness. And the drug which is acting as H3 inverse agonist is tiprolicent. Tiprolicent. The other name of the same drug is pitolisant. So pitolisant and tiprolicent are same drug. H3 inverse agonist for narcolepsy. Now H4 we have no drugs available. H3 drug we have discussed. The drugs blocking H2 are used in peptic ulcer like ranitidine, cimetidine. We will cover these in GIT. Here we will mainly discuss drugs blocking H1 receptors. H1 is causing allergy. So H1 blockers have anti-allergic uses. So here we will mainly cover antihistaminic drugs which are H1 blockers. Now H1 blockers we can broadly classify into categories: first generation antihistaminics and second generation antihistaminics. So first generation antihistaminic and second generation antihistaminic. The basic difference between the two groups is first generation antihistaminics can cross blood-brain barrier, whereas second generation cannot cross. So that means first generation antihistaminic can enter the brain and produce sedation by blocking H1 receptor. Second generation will not produce sedation. So that's why first generation antihistaminics are contraindicated in person requiring constant attention. Like truck drivers, pilots, we should not use first generation drugs. Second thing, first generation have additional anticholinergic properties, whereas second generation possess only antihistaminic property, no anticholinergic property. So because of anticholinergic properties, first generation antihistaminic can cause anticholinergic side effects like dry mouth, blurring of vision, urinary retention. All these side effects can come, whereas these are absent in second generation antihistaminics. But they can also be utilized for anticholinergic indications. So first generation antihistaminic can be used for anticholinergic indications also, like they can be used for motion sickness. Remember, in motion sickness we were using dicyclomine, hyoscine like drugs, which is anticholinergic. So here also we can use anticholinergic drug, that means first generation antihistamine. We can use it for drug induced Parkinsonism. Remember, drug induced Parkinsonism, drug of choice are central anticholinergic drugs. They can also enter the brain, they are also anticholinergic. We can use in drug induced Parkinsonism. We can use in muscular dystonias. So we can utilize them for anticholinergic indications also, apart from allergy. Remember, antihistaminics can be used for allergy, both first and second generation. But second generation are used only for allergy, whereas first generation antihistaminics have many more indications. That is the basic difference between first and second generation drugs. Now just we need to know the name of the drugs. Starting with the first generation antihistaminics. The examples of drugs are promethazine, diphenhydramine, dimenhydrinate, phenyramine, chlorphenyramine, cyclizine, cinarizine. These are some of the examples of first generation antihistaminics, and we discussed two properties of first generation drugs. Number one, they can cross the blood-brain barrier. Number two, they have antihistaminic activity, and both of them are maximum with promethazine. So promethazine has maximum entry in brain and it has maximum anticholinergic properties. So this is about the first generation antihistaminics. Now moving to second generation antihistaminics. The examples include terfenadine, fixofenadine, estamizole, loratadine, desloratadine, cetirizine, levocetirizine, agilastine, and olopatadine. These are examples of second generation antihistaminics. They do not cross the blood-brain barrier and they do not have anticholinergic properties. Now, among these, the special point to remember, terfenadine and estamazole, these are not used nowadays because they were causing QT prolongation. Risk of Torsades D point is QT prolongation is caused by terfenadine and estamazole. And one more drug was banned along with them for same reason. It was cisapride.
So three drugs, cisapride, estamazole and terfenadine. These were withdrawn because they were causing QT prolongation. These drugs in overdose, they block the potassium channels in the heart, and blockage of potassium channel result in increase in QT interval in ECG, which can result in Torsades D points. So because of this arrhythmia, these three drugs were withdrawn from the market. But why we will give overdose? Obviously we will not give. The problem was these were metabolized by an enzyme CYP3A4. This is a microsomal enzyme. So when they were given with enzyme inhibitors, there was a drug interaction. Enzyme inhibitor inhibited their plasma metabolism, and when metabolism do not occur, their concentration rise, and then the arrhythmias occurred. And the important enzyme inhibitors include ciprofloxacin, ketoconazole and erythromycin. So when any of these drug is given with any of these drugs, that can result in QT prolongation, and because of this side effect, these are withdrawn. Yeah? And again, from the name you can easily remember these drugs. We remember as cat drugs. C for cisapride, A for estamazole, T for terfenadine, and we know cat is cute, so cat is cute, so it causes QT prolongation. Cat is QT. Clear?
Now the last two drugs in this group, agilastine and olopatadine, they have maximum topical activity, means they are used locally as nasal sprays for allergic rhinitis or as eye drops for allergic conjunctivitis. So they are used locally. Fixofenadine is a metabolite of terfenadine, but it does not cause QT prolongation. So it is utilized till now. So these are the important points regarding the second generation antihistaminics also. Serotonin or 5-HT. Now serotonin has 7 receptors in the body, 5-HT 1, 2, 3, 4, 5, 6 and 7. Out of these, first 4 are well characterized. 5, 6 and 7 are present in brain, but we do not know exact function of these. So we will limit our discussion to 5-HT 1, 2, 3 and 4 receptors. So we have 5-HT 1 receptor, 2 receptor, 3 receptors and 4 receptors. Now 5-HT1 receptors are further of two types, 5-HT1A and 5-HT1B. So 5-HT1B are also written as 1D. On the other hand, 5-HT2 are written as 2A/2C. So we will discuss about these receptors. You can remember easily 5-HT1A receptor, A for agonist. That means if we stimulate 5-HT1A receptor, the drug will be used to treat A for anxiety. So drug stimulating 5-HT1A receptor are used for anxiety, and the drug which we use is buspirone. Buspirone is used for anxiety. 5-HT1A agonist for treatment of anxiety. Similarly, you can remember 5-HT1B receptor, B for blood vessels, B for brain. 5-HT1B receptors are present in blood vessels of brain, and their function is to cause vasoconstriction. So 5-HT1B 1D receptor agonist will cause vasoconstriction in brain, and we want to produce vasoconstriction in brain in case of headache. Yes, they are used for acute attack of migraine. So drug stimulating 5-HT1B 1D receptors, they are used for treatment of migraine, and the drugs are triptans. Any drug whose name ends with triptan is used for acute attack of migraine. The examples are sumatriptan, naratriptan, alitriptan, rizatriptan, and more drugs are also available in this category. So any drug ending with triptan is 5-HT1B1D agonist. It is used for acute severe migraine. In fact, they are drug of choice for acute severe migraine.
Migraine, we all know it is a unilateral pulsatile headache. The major reason of migraine is assumed to be inflammation and dilatation of blood vessels in the brain. So basically neurogenic inflammation and dilatation of blood vessels, and the latest theory states that migraine occurs due to release of calcitonin gene related peptide from the trigeminal neurons in the brain. CGRP, it does two important things. One, it causes inflammation, and second, it is a powerful vasodilator. So these are the two major components in migraine headache. So how to treat migraine? For treatment of migraine, first of all, we will try to treat it by non-steroidal anti-inflammatory drugs, so which are usually considered the drug of choice. Drug of choice for migraine are non-steroidal anti-inflammatory drugs. Paracetamol, diclofenac, these drugs are used. If the attack is not controlled by these cases, then it is considered the severe attack. So for acute severe attack, the drug of choice are triptans. Triptans, they are drug of choice for acute severe attack. The examples of triptans include sumatriptan, naratriptan, rizatriptan, alitriptan, frovatriptan, and many triptans are there. These are drug of choice for acute severe migraine. Now, triptans, first of all, how they work. Triptans act by stimulating a receptor called as 5-HT1B/1D receptor. This receptor is present at two places. One, it is present in the blood vessels, where this receptor causes vasoconstriction. So when we stimulate this receptor, vasoconstriction occurs. Second, this receptor is also present on the trigeminal neuron, where it inhibits the release of calcitonin gene related peptide. And we know calcitonin gene related peptide result in vasodilation. So vasodilation will not occur. And second, it causes inflammation. So inflammation will not occur. So 5-HT1B/1D receptor agonist, that means triptans, they directly cause vasoconstriction also, and they indirectly inhibit CGRP release and benefit the migraine attacks. So triptans are drug of choice for acute severe migraine. One more drug which can stimulate this receptor, 5-HT1B/1D receptor, is ergotamine. So ergot alkaloid, ergotamine, the name says ergotamine also stimulate 5-HT1B/1D receptor. So it can also be used in acute severe migraine. But problem with ergotamine is ergotamine increase the vomiting associated with migraine, whereas triptans, they decrease the vomiting associated with migraine. So triptans are drug of choice for acute severe migraine. Ergotamine can be used, but we normally do not prefer. But remember, both triptans and ergotamine together should never be given. Now, main problem with both ergotamine as well as triptan is they can cause vasoconstriction and they can cause coronary artery spasm. So, due to coronary artery spasm, they are avoided in patient with coronary artery disease. Clear? So, this is about acute attack of migraine. Now, some people, they develop frequent attacks. So we want that the attack should not happen. So we can give prophylaxis of migraine. We have several drugs which can be used in prophylaxis of migraine. The important ones you can remember as A, B, C of migraine. ABC of migraine, important drugs you can remember. On A, we have two important group of drugs. One are called antidepressant drugs, imipramine etc. we can use. Imipramine, amitriptyline, these can be used. Then second, we have anti-epileptic drugs. anti-epileptic drugs like valproate, topiramate, gabapentin also. So we can use to prevent migraine. On B, again we have two drugs. Main is beta blocker, propranolol. In fact, propranolol is a drug of choice for prophylaxis of migraine. Drug of choice for prophylaxis of migraine. We can also use botulinum toxin in case of attacks which are not controlled by any other drug. Botulinum toxin is given as injection on the forehead, so it will relax these muscles and the headache will stop. Okay? So it is used only when other drugs fail. Then on C, we have two drugs again. One is calcium channel blocker. One calcium channel blocker which is specifically used for migraine is flunarizine. Then the new drugs which are approved in migraine, these are calcitonin gene related peptide antagonist. The drugs stopping the action of calcitonin gene related peptide. These include drugs like aranumab. These are monoclonal antibody against CGRP. Aranumab, fremanezumab, and galcanezumab. Aranumab, fremanezumab and galcanezumab. These are monoclonal antibodies against CGRP. They are indicated in prophylaxis of migraine. And lastly, on M we have methisergide, which is an ergot derivative. Because of risk of pulmonary fibrosis, we do not prefer nowadays. When we were using earlier, it was given for 6 months and then break of 1 month must be given. Okay? So these are the different drugs which can be used to prevent migraine. Clear? Now we will move to some new drugs in migraine. We just discussed calcitonin gene related peptide is assumed to be the major culprit in migraine. So CGRP, it causes vasodilation, it causes neurogenic inflammation. One target we discussed that on the blood vessels there is presence of 5-HT1B1D receptors. So if we stimulate them, vasoconstriction can occur. Then on trigeminal neuron also we have 5-HT1B1D receptors. So when we stimulate this receptor, CGRP decreases, so we can treat migraine. So we discussed triptans. They act by both of these mechanisms. Triptans as well as ergotamine, they stimulate 5-HT1B1D receptor on the blood vessels, leading to vasoconstriction. They also stimulate the 5-HT1B1D receptor on the trigeminal neuron and inhibit the release of CGRP. But problem is, by acting directly on the blood vessel, they can cause vasoconstriction, which can lead to coronary spasm, which can even worsen hypertension. So we want a drug which do not act directly on the blood vessel. The drug should act on CGRP only. Okay? So what we found is, on the trigeminal neuron, one more receptor is present, which is called as 5-HT1F receptor. This receptor is not present on the blood vessels. So we have developed a new drug very recently which is approved, the drug which stimulates 5-HT1F receptor. So if we stimulate this, CGRP will decrease and that will prevent vasodilation and inflammation. So it can treat the acute attack of migraine. And that drug which is approved is lasmiditan. Basically, the drugs end with the ditan. So lasmiditan is a drug which stimulates 5-HT1F receptor, decrease CGRP and prevent vasodilation and inflammation. So lasmiditan is recently approved for acute attack of migraine. It is approved for acute attack of migraine. It stimulates 5-HT1F receptor and inhibit the release of CGRP. Clear? Then second we discussed, we have monoclonal antibodies against CGRP. And the drug which are monoclonal antibody against CGRP are aranumab, fremanezumab, and galcanezumab. So this is about the drugs used in migraine. Okay.
This is about the 5-HT1 receptors. Now coming to 5-HT2 receptors, if you remember, we discussed in central nervous system the drugs which block 5-HT2 receptors, they are used as atypical antipsychotic drugs. So the drugs like clozapine, olanzapine, these are 5-HT2 antagonists and they are used in antipsychotic function. If you remember, what is the common side effect of all the atypical antipsychotic drugs? Yes, they cause lipodystrophy syndrome, means weight gain, hyperglycemia like thing. So when 5-HT2 receptor blocker is causing weight gain, if we stimulate 5-HT2 receptor, can we get weight loss? So on the basis of this hypothesis, we developed a drug which stimulates 5-HT2C receptors and it was actually causing weight loss. So that drug has now been approved for obesity and the name of the drug is lorcaserin. Lorcaserin. It is 5-HT2C agonist. It is used to produce weight loss. Used in obesity. It is approved by FDA for obesity now. And from the name you can remember the important findings. Serin means serotonin. C means 2C agonist. Serotonin 2C agonist. It is used to lower the weight loss. Lorcaserin.
One more 5-HT2 blocker is flibanserin. Flibanserin is a new 5-HT2 blocker. It is indicated in HSDD. The full form is hypoactive sexual desire disorder in females. So it is used to treat hypoactive sexual desire disorder in females. If we talk in simple language, it basically increases the libido in females. By increasing the libido, it will decrease or treat this problem. And from the name you can find everything. The name says serin. Serin means serotonin antagonist. So it is a serotonin antagonist. The name says it is a serotonin antagonist and used for, again from the name you can remember, it is used for F means female, LIB means libido. So it is used to increase female libido. So that means hypoactive sexual desire disorder. Okay.
So this is about the 5-HT2 receptors. 5-HT3 receptors. 5-HT3 receptors are present in the CTZ, chemoreceptor trigger zone. When we stimulate 5-HT3 receptors, vomiting occurs. So if a drug blocks 5-HT3 receptors, it can be used to treat vomiting. And the drugs are 5-HT3 antagonist drugs. The name ends with cetron. Drugs like ondansetron, granisetron, propisetron, palonosetron, all these are 5-HT3 antagonists and these are drug of choice for chemotherapy induced vomiting. They are drug of choice for vomiting due to chemotherapy. They are also drug of choice for radiotherapy induced vomiting. And now they are also drug of choice for post-operative vomiting. So chemotherapy induced, radiotherapy induced and post-operative vomiting, drug of choice are 5-HT3 antagonists like ondansetron. Now the last serotonergic receptor is 5-HT4. It is present in the GIT and it increases the forward movement of GIT. So simply peristalsis. And the drugs which stimulate the forward movement of GIT are called prokinetic drugs. So if we stimulate 5-HT4 receptors, the drug will be used as prokinetic. And the drugs stimulating 5-HT4 receptors are cisapride and mozapride. These are utilized in gastroesophageal reflux disease. Cisapride we already discussed, it is withdrawn now because of QT prolongation. Remember, cat is cute. QT prolongation. So mozapride is used for gastroesophageal reflux disease. But remember, drug of choice for GERD are proton pump inhibitors. Mozapride is used, but drug of choice se fast in the exam, it is proton pump inhibitors. That is all about the drugs acting on serotonergic receptors. That means we have completed the amine autocoids.